So let's talk about some of the medications that people who have heart disease commonly take. They could be on any combination of these, plus they could be taking other medications, because as we've been talking about all semester, many people have multiple chronic diseases. So they may have heart disease, they may have diabetes, they may have arthritis, they could have anxiety, depression. So people can be on multiple medications, but typically medications that help lower the myocardial oxygen demand. Beta blockers, they're also used for blood pressure, but if someone has had a heart attack, it helps the heart contract. Diuretics, also used for blood pressure, can be used for people who have heart failure that have a lot of fluid buildup. Nitroglycerin, yes, it's that stuff that you used to see on Bugs Bunny that was explosive. It does help dilate the coronary arteries so that there's more oxygen reaching the heart muscles. Again, antihypertensive, other types of blood pressure medications. There are calcium channel blockers. There are, ACE inhibitors. We talk about those in XPhys too. Lipid lowering medications, so cholesterol medications, drugs for arrhythmias. So if someone's had a heart attack or they've had heart surgery and their heart has been cut into, they are at risk of serious arrhythmias that could be life-threatening. So people could be on multiple medications for their heart. How do they do exercise testing with cardiac populations? The Bruce protocol is probably one of the most common. So that's going to be done in a clinical setting, so hospital or outpatient cardiologist office with electrocardiogram monitoring. And they can actually see on the electrocardiogram, is there myocardial ischemia? Is the ST segment on the ECG depressed? So the ECG is 100 years old, but it's a great diagnostic tool. Typically, there is going to be an MD supervision. He or she may be in the room or they may just be in the building. Obviously, if you're in a hospital or an outpatient doctor's office, you're going to have a physician close by. It probably is going to include at least an MS level exercise physiologist, so with extensive training in cardiac rehab. When we were doing the cardiac rehab program at Virginia Tech, if we didn't have the physician there, we couldn't test. So if the physician had an emergency and he or she couldn't be there, we could not test. So, but in a lot of facilities, that's not going to be a problem. So where people are pushed, we try to get as good of max data as we can. So we want to at least get them to where normal activities will occur, especially if they are, if they have to deal with employment possibilities, and where they get symptoms. So are they getting chest pain? Are they getting shortness of breath? Are they seeing changes on the ECG? So that's what they want to see on the treadmill test. They may or may not use a metabolic cart to get VO2 max. And that can be important because if someone has a very poor VO2 max value, that is going to lead to increased risk of death. So if their total VO2 max is 4 mets, so 4 times 3.5, about 13 milliliters per kilogram per minute, that is very, very low. So that can increase risk of death and increase likelihood of complications. They can do cycle testing. It's much harder to do a max test on a cycle because people tend to have poor leg strength and they're not as familiar with the cycling mode of exercise as they are with walking. Although some people don't do all that well on treadmill walking either, and they can find that challenging. They can do other types of testing like pharmacological induced testing. If someone really cannot exercise, it can mimic an exercise test. But if they can try to get exercise data on them, they're going to try to do that.